Okay, I've got a couple of readies. All right, so this is the first question. This patient has COPD exacerbation and the patient has been prescribed prednisolone and amoxicillin. The patient is on aspirin, citalopram, bisoprolol, ramipril, and atorvastatin. So what advice would you give to the GP concerning this prescription? A, B, C, D, or E? What advice would you give to the GP concerning this prescription? For COPD exacerbation, what advice would you give to the GP? So I've got a couple of C's. Does everyone agree? So this patient is already on aspirin and citalopram coupled with the other medications for cardiovascular prevention, atorvastatin, ramipril, probably for blood pressure and the rest, okay? And now the patient has been prescribed prednisolone in addition to the prednisolone that the patient takes every single day. So this patient is at high risk of gastric irritation, okay? And the patient will need a proton pump inhibitor. So well done to everyone that typed C, right? The patients would need a PPI to cover up and prevent extra gastric side effects. So the answer is C. Recommend that the GP prescribes a proton pump inhibitor together with the prednisolone. Okay, so now let's quickly look at prednisolone, or let's start with PPIs, right? Obviously, this patient might be on a PPI for short term, so that's fine. But for those on PPIs for long term, what are the possible long-term side effects of proton pump inhibitors? What are the possible long-term side effects of proton pump inhibitors? Anyone? So I've got low magnesium from Temilola, okay? Increased risk of bone fractures, okay? What else? Hypomagnesemia, increased risk of fractures. Yes. SLE, C. difficile infection. Yes. Proton pump inhibitors also mask gastric cancer, okay? It could mask the symptoms of gastric cancer. So those are long-term side effects of proton pump inhibitors, right? So omeprazole, is it an enzyme inhibitor or is it an enzyme inducer? Yes, omeprazole is an enzyme inhibitor. Okay, so coupled with all the side effects of PPIs, it could also inhibit the metabolism of some drugs and could lead to um, increased side effects, right? So that's important as well. Then let's talk about the steroid. This patient is on prednisolone 10 milligram once daily. What are the possible long-term side effects of steroids? So psychiatric side effects, steroid causes weight gain. Okay. Would steroids cause hypertension or hypotension? What's the effect of steroids on the blood pressure? Is it hyper or hypotension? Yes, steroids could cause increased blood pressure. Okay, so one of the monitoring requirements for patients on long-term steroids is blood pressure check. Okay, so with regards electrolytes, what's the effect of steroids on sodium? Is there any effect of steroids on sodium? Is it hypernatremia or hyponatremia? Is it hypernatremia or hyponatremia? Steroids. Steroids would cause hypernatremia, okay? So remember that high levels of sodium causes increased blood pressure. So if you remember that steroids cause hypertension, then you should also remember that steroids will cause hypernatremia. So increased sodium levels. Okay, what about potassium? What's the effect of steroids on? Yeah, so steroids will cause hypokalemia, steroids will cause hypernatremia, steroids will cause hypertension, Steroids would also cause weight gain, osteoporosis, and muscle wasting. Those are long-term side effects of corticosteroids. Okay? Are steroids best taken on an empty stomach or after food? Is it best taken on an empty stomach or after food? After food. Remember that it causes GI irritation, so it's best taken after food. Would you advise your patient to take prednisolone in the morning or at night? Would you advise your patient to take prednisolone in the morning or at night? In the morning. Why? Why should prednisolone be taken in the morning? Yes, it could cause sleep disturbances. It could cause insomnia. So that's one of the side effects of steroids. So we've looked at side effects of proton pump inhibitors. We've looked at side effects of steroids. Someone mentioned PPIs interact with clopidogrel. So would omeprazole increase the efficacy of clopidogrel, or will it decrease the efficacy of clopidogrel? Will it increase the efficacy of clopidogrel or decrease the efficacy of clopidogrel? It decreases. The reason is because omeprazole inhibits the conversion of clopidogrel into its active form. Remember we said it's an enzyme inhibitor. So it inhibits the conversion of clopidogrel into its active form, because clopidogrel is a prodrug. Okay, so clopidogrel needs to be converted to an active form to work properly. So omeprazole inhibits this conversion, and therefore we're going to have decreased efficacy. So would the patients be at increased risk of bleeding or at increased risk of blood clots? Clots, yeah, because clopidogrel should is an anticoagulant, so it should help prevent blood clots. So if the patient is taking omeprazole with clopidogrel, that could increase the patient's risk of blood clot. So what PPIs can be used? For example, if you get the question of a patient has H. pylori um, infection and you want to prescribe a PPI and the patient is on clopidogrel, what PPIs would be fine? Yes, lansoprazole, pantoprazole. So omeprazole is affected by clopidogrel, or rather clopidogrel is affected by omeprazole, and also esomeprazole. Yes. So IA said avoid esomeprazole and omeprazole. So those two should be avoided with clopidogrel. Now, in terms of COPD exacerbation, which this patient is trying to treat, what's the what's the dose of prednisolone? What's the duration of therapy and dose for COPD exacerbation? What's the duration for COPD exacerbation? Yeah, so 30 milligram for 5 days. Okay, 30 milligram daily for 5 days. And remember, how would you advise the patient to take it? Is it all at once, or would the patient need to split the tablets? Yes, all at once. Yes. So 30 milligram for 5 days for COPD exacerbation. What about for asthma, acute asthma exacerbation? 40 to 50 milligram daily for 5 days for asthma, while 30 milligram daily for 5 days for COPD. So what antibiotic is used for prophylaxis for COPD exacerbations? What antibiotic is usually used as a preventive azithromycin? That's correct. What's the dose? How is azithromycin going to be taken? Yeah, so 40 milligram is a bit high for COPD exacerbation, but when it comes to MCQs, you need to choose the most appropriate option. Okay, so in this case, recommending a PPI is a better option. So it's 250 milligram. Is it CDS or 3 times a week? So it's usually given tries 3 times. Okay, 3 times a week. Thank you, Aisha. That's the dose of azithromycin for prevention of COPD exacerbations. Now we've got amoxicillin being prescribed as well for infective COPD exacerbation. Okay. What other antibiotic is usually used? If the patient has got penicillin allergy, for example, what would you prescribe for COPD exacerbation treatment? Doxycycline, yes. Doxycycline is correct. So sometimes patients are prescribed doxycycline, sometimes patients are prescribed amoxicillin as a rescue pack for infective COPD exacerbation. How you know it's infective is, how would you know that it's infective? How would you know? The sputum, yes, colored sputum. Colored sputum is indicative of infective COPD exacerbation. Yeah, so clarithromycin is also an alternative. So in terms of long-term use of steroids, can steroids be withdrawn abruptly or not? No, don't withdraw it abruptly. So in what cases do we consider tapered dose reduction? After how many weeks? After how many weeks of treatment? 3 weeks. So don't forget 3 weeks of treatment. So if the patient has used steroids for 3 weeks and above, then regardless of the dose, you will need to taper it gradually. Okay. And what else? What are the other reasons why we would need to reduce the dose gradually of steroids? What are the other reasons why we would need to gradually taper the dose? Yes, over 40 milligrams. So if you go to your BNF, there's a section that lists criteria that for steroids to be withdrawn gradually, gradual dose reduction. Okay, one of them is if the patient has had the steroid for more than 3 weeks. Another is if the patient has had 40 milligram for more than 1 week, more than 40 milligram for more than 1 week. Okay, so there's a couple of criteria, more than 1 year as well. Okay, so all of this is to prevent adrenal crisis, which could be fatal. So gradual withdrawal of steroids is important. All right, so I'll move to the next question. So aside this, what other medications can increase the risk of bleeding aside the steroid? The patient is on some medications. Which ones can increase? SSRIs, yes. What else? The aspirin, yes. Aspirin, citalopram, anticoagulant, antiplatelets. All of these medications can increase risk of bleeding. Even your bisphosphonates as well. Those ones can cause gastrointestinal side effects. So that's worth remembering. All right, next question. You're working in a community pharmacy and receive a private prescription for a 15-year-old patient. The prescription is for clonidine, 100 microgram tablets to be taken at night to help with sleep. Which of the following statement is correct regarding this private prescription? Yes. Well done, IA, Temilola, Tamin, Henry, Blessed, and Gloria. The correct answer is C, okay? The prescription is valid for 6 months. Okay, what's the validity of NHS prescriptions as well? This is a private prescription. What's the validity of NHS non-CD prescriptions, non-controlled drug prescriptions? 6 months, yeah. So validity of prescriptions generally is 6 months if they are non-CDs, okay, regardless of if it's private or if it's an NHS prescription. Okay, so what prescriptions have a validity of 28 days? So option B says the medicine must be dispensed within 28 days of prescription. Which ones have a validity of 28 days? CDs. What schedule of CDs? Is it 2 and 3 or 2, 3 and 4? Because a few people wrote 2 and 3, a few people wrote 2, 3 and 4. So which one? Yes, 2, 3, and 4. Okay. So schedule 2, 3, and 4 control drugs have a validity of 28 days. Your diazepam is valid, prescription for diazepam is valid for 28 days. Prescription for clonazepam for any schedule 2, 3, and 4 control drug. Okay. So my question now is, if this private prescription was for, say, Zomorph, if it was for Zomorph, what kind of form is required? What kind of prescription form is required for private CD prescriptions? Yes, the pink one, right? FP10 PCD. FP10 PCD. Okay. And what's the requirement on that prescription? What do we need to see? What detail of the prescriber do we need to see on the prescription? There's a number. What's it called? Aside the GMC, for private prescriptions, what's it called? Does anyone know? Yeah, so it's called PIN. Okay, for private prescriptions, private CD prescription, private identification number. Okay, so that's important as well. And what will be the fate of private prescriptions? What would you do with the prescription? Is it meant to be retained in the pharmacy or not? Yes, CD, if it's a CD private prescription. Yes, you need to send the original to NHS BSA and make a copy and retain in the pharmacy. So send the original to NHS, make a copy and retain in the pharmacy if it's a controlled drug prescription, right? And we said it's valid for 28 days. So generally, what's the fate of private non-CD prescriptions? If it's a non-controlled drug and it's a private prescription, what do we do with the prescription? Do we send it as well? No, not for a CD. Yeah, so all private prescriptions should be kept in the pharmacy for 2 years. Okay, it should be kept in the pharmacy for 2 years. And finally, what is the recommended duration of supply required for controlled drugs? 30 days. Is that good practice or is that a legal requirement? It's good practice. Well done, everyone. All right, so that's it for this one. I've got a couple of CDs. So which of these control drugs on my screen are Schedule 3 CDs that require safe custody? Which of these control drugs on my screen are Schedule 3 CDs that require safe custody? Which one? Which ones are Schedule 3 CDs that require safe custody? Well done, IA. Well done, Aisha. Well done, Jazz. Well done, Theophilus. Well done, Taiba. Buprenorphine and temazepam. Henry, morphine is not Schedule 3. Okay, morphine is Schedule 2. So buprenorphine and temazepam are Schedule 3 CDs. Remember that generally, not all Schedule 3 CDs would require safe custody. Not all Schedule 3 CDs should be kept in the control drug cupboard, but buprenorphine and temazepam require safe custody. Okay, tramadol belongs to what schedule? 1, 2, or 3? Tramadol is also Schedule 3, but it doesn't require safe custody. So true or false? Records of tramadol supplied to a patient must be entered on the CD register. Is that true or false? False, yes. Remember that Schedule 3 CDs are CD no reg form, so we don't require details to be entered in the CD register. Okay, so Schedule 2 CDs should be entered. Details of Schedule 2 CDs supplied and received should be entered in the CD register, but not Schedule 3. All right, so codeine 50 milligram tablets, what schedule does that belong to? Codeine is Schedule 5, yeah. So tramadol is Schedule 3, temazepam is Schedule 3, morphine is Schedule 2, diazepam is Schedule 5, and buprenorphine is Schedule 3. That's just a quick recap for you. Morphine is Schedule 2. Okay. All right, let's look at this question on my screen. Diazepam is Schedule 4. CD Benz POM, that's what Schedule 4 Part 1 drugs are. All right. So about this 35-year-old woman who needs to purchase pseudoephedrine, which of these options is most appropriate? A, B, C, D, or E? Which of these options is most appropriate for her? A, B, C, D, or E? Yes, well done, IA, Taiba, Motion, and everyone who has answered this correctly. Okay, so Taiba said maximum is 720 milligram. That's correct. So the maximum you can sell at a time is 720 milligram of pseudoephedrine, right? Option E says she may buy 2 packs, which is wrong. She can't buy more than 720 milligram at a time. So she can't buy 2 packs. Option E is wrong, right? Option B is correct because it says she may buy a single pack of pseudoephedrine, 360 milligram. All right. So what about ephedrine? What's the maximum that can be sold at the time for ephedrine? So 720 milligram for pseudoephedrine and 180 milligram for ephedrine. And what's the reason that the sale of these medications are regulated? What's the reason? What's the reason? Abuse, yeah. They've been known to be used for the illicit production of crystal methyl amphetamine. That's why we need to make sure that people are buying it for the right purpose, and legally you're not allowed to sell more than 720 milligram of pseudoephedrine and more than 180 milligram of ephedrine. Okay. With regards to the ephedrine, does anyone know what the age licensing is for Sudafed? Sudafed is a brand name. What's the age licensing for pseudoephedrine tablets? So I've got 12 from Blessed. Okay, Side said 12. Tamin said 12. That's correct. 12, okay? 12 years and above. That's the age licensing for Sudafed tablets. What about the liquid? It also comes as a liquid. What's the age licensing for the liquid? 6. Well done, Blessy and Blessed. 6 is the age licensing for the liquid. What are the contraindications to the sale of pseudoephedrine? What are the reasons, medical reasons you won't be able to sell pseudoephedrine? Hypertension, okay? What else? Yes, MAOIs. What's the interaction between pseudoephedrine and MAOIs? I think we talked about it in our last session. What's the interaction between pseudoephedrine and MAOIs? Hypertensive crisis. Okay, that's correct. What about if the patient is on sertraline? It could also cause serotonin syndrome. It could cause serotonin syndrome. Well done, Blessed. Okay, so you need to always look out for. That's why it's important that when a patient comes into the pharmacy, you need to actually really check if they're on other medications. Okay, to prevent interactions like this. So hyperthyroidism is also correct. Blessed mentioned hyperthyroidism, hypertension, MAOI. Those are reasons. Um, those are contraindications to the sale or to the use of pseudoephedrine. Okay. So what alternative would you recommend if a patient cannot use pseudoephedrine? A patient with blocked nose, congested nose, nasal congestion, what alternatives would you recommend? Or in terms of lifestyle advice, saline, yes, saline is recommended, yes, doesn't really have any contraindication. Saline stimulation as well. Stimulation is a safer alternative to the use of pseudoephedrine. All right, next question. A 72-year-old man is admitted to the hospital with a suspected ischemic stroke. He has type 2 diabetes and takes atorvastatin 20 milligram once daily. He's not eligible for thrombolysis. Which of the following antiplatelet regimens is most appropriate to start? A, B, C, or D? Okay, I've got a couple of B's. Well done, everyone that attempted this question. Blessy said B. Temilola said B. Blessed said B. Okay, all right, that's fine. B is actually correct. Okay, aspirin 300 milligram once daily for 14 days, then clopidogrel 75 milligram once daily, long term. So this question says the patient is not eligible for thrombolysis. Okay, when it comes to thrombolysis, obviously, when it comes to stroke means that the patient's brain function has declined due to impaired blood flow due to the formation of clots. Okay, sudden loss of brain function either caused by blockage or a bleed in the case of hemorrhagic stroke. In this case, they said the patient is not eligible for thrombolysis. What's the eligibility criteria for thrombolysis? In terms of ischemic stroke management, what's the eligibility criteria? Within 4.5 hours. Well done, IA, Temi, S, and Side. Yes. And Blessed. Within 4.5 hours, we can give alteplase for the management of ischemic stroke to help break down the blood clots. Okay. So within 4.5 hours, we can give alteplase. Remember, that's for ischemic stroke. After 4.5 hours, the benefits do not outweigh the risks, so we are not going to do alteplase any longer. Okay, so quick recap on stroke. Stroke is a sudden loss of brain function caused by either a blockage or a bleed. Blockage in terms of blood clots. So what group of medications are used for the management of stroke? What group of medications are used for the management of stroke? Is it anticoagulants or antihypertensives or beta blockers or antiplatelets? What group of medications are used for the management of stroke? Antiplatelets, yes. Antiplatelets generally are used for the initial management of stroke. So statins are used if the patient has basically for secondary prevention, but for the immediate management initially, antiplatelets can be used for stroke management. And there are three types of stroke that you need to know for your exams: a transient ischemic attack, an ischemic stroke, and hemorrhagic stroke. Okay, so the difference is that with TIA is more like a warning sign. It's a temporary blockage and it resolves on its own within 24 hours. Most times, TIAs, transient ischemic attacks, resolves within a couple of minutes. Okay, but generally, we would say they resolve within 24 hours. So, if a patient presents with symptoms of TIA, what's your treatment strategy initially? What's your treatment strategy initially for TIA? The patient presents within 24 hours. Okay, so aspirin is correct, but is it just aspirin we would give? Is it just aspirin that we're going to give? Yes, so dual antiplatelet therapy can be given for management of ischemic stroke, especially if the patient presents within 24 hours. Okay, so aspirin and clopidogrel, yes, if there is low risk of bleeding, because obviously you don't want to give dual antiplatelets to someone who has a high risk of bleeding. Okay, so high risk TIA dual antiplatelet therapy. Aspirin 300 milligram can be given as a loading dose, and then subsequently we're going to give 75 milligram of aspirin and clopidogrel 75 milligram, just because of the risk associated with TIA. We don't want the person to come down with a full-blown stroke, so we need to attack initially with dual antiplatelet therapy if the patient can tolerate it. Okay, so once the patient has been assessed and confirmed that this is a TIA, dual antiplatelet therapy for suspect for initial treatments. So after 21 days, would switch to a single antiplatelet therapy. Clopidogrel 75 milligram is recommended. So in terms of ischemic stroke, we've already said 4.5 hours is the timeline. If it's within 4.5 hours, then we should consider alteplase. Okay, but before then, remember that we need to do a CT scan to check that the patient has not got hemorrhagic stroke. Okay, because we can't give antiplatelets if the patient has hemorrhagic stroke. That would further worsen the situation because of the bleeding. So we alteplase after CT scan has confirmed that this is an ischemic stroke. Okay, how long do we give aspirin? How long do we give aspirin for? Yeah, so remember, for ischemic stroke, aspirin is given for 14 days. After 14 days, switch to long-term antiplatelet therapy, which is clopidogrel. So that's summary in terms of management of stroke. We've also got hemorrhagic stroke. Hemorrhagic stroke sometimes will require surgery to help correct the bleeding ongoing in the brain. And then it talks about blood pressure that needs to be monitored and lowered if required. And obviously, when it comes to secondary prevention, what medication are we going to give for secondary prevention of stroke? Yes, 80 milligrams statins should be given. 80 milligrams statins should be given for secondary prevention of stroke. All right. Yes, if the patient requires antihypertensives, then that should be given as well. Next question. A 54-year-old woman who is a regular patient at your pharmacy comes to collect a repeat prescription for sulfasalazine. She's experiencing fatigue and yellowing of the eyes. These are current medications. Which of the following most likely explains our presenting symptoms? Fatigue and yellowing of the sclera. Okay, so Taiba said D, Gloria said D, Park said D, Timilola said D, Bless said D. Okay, yes, you're correct. IA. This is a side effect of sulfasalazine as a result of liver toxicity, hepatotoxicity. So remember, we've been revising symptoms of hepatotoxicity. We said fatigue, we said dark urine, yellowing of the eyes, jaundiced eyes, abdominal pain. Those are symptoms of hepatotoxicity. In this case, clindamycin doesn't really have anything to do with the side effects it's experiencing. Cellulitis does not really have anything to do with fatigue. What are the symptoms of cellulitis? What are the key symptoms of cellulitis? Okay. Pain, yes. Redness of the affected area. It could feel warm to touch. Okay. It could feel hot to touch, cellulitis. And sometimes the symptoms of cellulitis overlaps with which other cardiovascular condition? DVT. Yes, thanks, Blessed and Timnola. So swelling of the leg usually affects the lower limb, redness and pain. Those are symptoms of cellulitis, and it's treated with what antibiotic? What's the first line for the management of cellulitis? Flucloxacillin. And what if the patient has got penicillin allergy? Macrolides. Perfect. Okay, so that's just by the way for this question. This question is testing you on sulfasalazine causing hepatotoxicity. So the answer is D. All right, so looking at sulfasalazine, what are the other key side effects? Sulfasalazine causes hepatotoxicity. What about renal? Is it nephrotoxic as well or not? Sulfasalazine nephrotoxic. Yes, it is. So renal impairment. So one of the monitoring requirements for sulfasalazine is U&Es as well to check for nephrotoxicity. So hepatotoxicity, renal impairments. Okay, IA mentioned blood dyscrasias. So blood sulfasalazine causes blood dyscrasias. And what symptoms would you look out for in patients who have got blood dyscrasias? Sore throats. Okay. easy bruising as well, bleeding. Yes, those are symptoms. Mouth ulcers, those are symptoms of blood dispersals common to sulfasalazine. Sulfasalazine is used for what condition? Management of what condition? Yes, it's used for inflammatory bowel disease. It could be used for rheumatoid arthritis. It's an immunosuppressant, so it could be used for inflammatory conditions like Crohn's disease and ulcerative colitis as well. Okay, so sulfasalazine colors urine. Don't forget that. So quick recap on other medications that colors urine. Which anti-diarrhea medication causes, sorry, constipation? Which medication for constipation colors urine? Senna, yes. Which other one aside Senna? Which other one aside Senna that is useful in patients who have got cancer? Codantrama, yes, codantrama. Remember when we did Parkinson's disease in the last session, we also mentioned that levodopa and entacapone can also cause urine coloration. All right, so let's quickly recap on medications that are hepatotoxic. So I've got methotrexate and lithium. Which of these two are hepatotoxic? Which of these two are hepatotoxic? Everybody agrees methotrexate is hepatotoxic. Lithium affects what organ? Lithium affects the kidney. Okay, methotrexate affects both kidney and liver. Lithium affects the kidney. So the answer to this question is methotrexate. So the next one, amiodarone and digoxin, which is hepatotoxic? Amiodarone and digoxin, which is amiodarone. That's correct. What's the capped dose of amiodarone with simvastatin? What's the capped dose of statin rather with amiodarone? 20 milligram. Okay, that's correct. And don't also forget that amiodarone and statin together can also increase the risk of hepatic impairment because statins are also hepatotoxic. So I've got isoniazid and amlodipine, which is hepatotoxic. Which one is hepatotoxic? Isoniazid, that's correct. Okay. Valproate or gabapentin, which one? Sodium valproate. So regards isoniazid, remember that most medications for tuberculosis are hepatotoxic. And same with anti-epileptics, sodium valproate, lamotrigine, carbamazepine, most of them have issues with the liver. So that's worth remembering as well. Carbimazole and levothyroxine. Carbimazole is hepatotoxic, yes. Statins or atenolol. Statins, that's correct. So regards to carbimazole, what major side effects do you remember aside hepatotoxicity? Pancreatitis, blood agranulocytosis, yes. Carbimazole is agranulocyte, can cause agranulocytosis. All right, so rifampicin or metformin. Rifampicin is hepatotoxic. Is rifampicin an enzyme inducer or an enzyme inhibitor? It's an enzyme inducer, that's correct. What about valproate, sodium valproate? Is sodium valproate an enzyme inhibitor or inducer? Sodium valproate is an enzyme inhibitor, correct. So rifampicin is an enzyme inducer. Sodium valproate is an enzyme inhibitor. This 68-year-old man with atrial fibrillation is initiated on amiodarone therapy. Given its long half-life and risk of serious side effects, which of the following laboratory parameters should be monitored? A, B, C, or D? A is correct. Yes, thyroid function test and liver function test. Okay, remember we just said that amiodarone is hepatotoxic, so A should be monitored. So let's quickly recap on amiodarone. Okay, so Other side effects of amiodarone, I've always used patch, PATCH. So let's start with P. What are the side effects of amiodarone that starts with P? Pulmonary toxicity, okay. Photosensitivity, okay. What else? What's the effect of amiodarone on potassium levels? What's the effect of amiodarone on potassium levels? Hypokalemia, yes. Hypokalemia. So amiodarone. So that's another way to remember. P for photosensitivity or phototoxicity. P for potassium, which is hypokalemia. P for pulmonary toxicity. Okay. What other high risk drug causes pulmonary toxicity? I think we discussed this last session. Which one? If the patient presents with shortness of breath, coughing, what could be the side effects? Methotrexate, yes, it could be methotrexate, it could be nitrofurantoin. All right, so there is another P as well, which is peripheral neuropathy. Amiodarone also causes peripheral neuropathy. So, but hypokalemia, that's correct. So A is just for amiodarone, so don't bother with that. Then I've got hypokalemia, not hypokalemia. I've got C. What are the side effects of amiodarone? That starts with T. What's this T for? Which one? T, not C. Thyroid, right? Yes, thyroid. So is it hypo or hyperthyroidism? Or is it both? Both, yes. Amiodarone can cause both hypo and hyperthyroidism. And we've got C as well. What's C for? What's C for? Corneal microdeposits and cardiac toxicity. So in terms of cardiac toxicity, remember we said hypokalemia, so it could cause QT prolongation, it could cause corneal microdeposits. And finally, we've got H, which is what? Liver, right? Hepatotoxicity. Yes, hepatotoxicity. So this is a good way to remember amiodarone. And once you remember the side effects, it's easier to remember the the monitoring requirements for amiodarone. It's easier to remember the monitoring requirement. Chest X-ray should be monitored because of the cardiac side effects. Potassium as well should be monitored. Liver function should be monitored before treatment and every 6 months. We've said amiodarone and simvastatin. What's the possible side effects with those two medications? Amiodarone and statin, hepatotoxicity, and also rhabdomyolysis as well, because amiodarone could inhibit the metabolism of statin and could cause rhabdomyolysis. What are the cautionary labels for amiodarone? Which ones? What are the cautionary labels? Your BNF cautionary label. So Bless said avoid sunlight. Gloria said photosensitivity. Yes, don't forget that. That's one of the BNF cautionary labels for amiodarone. What else? Actually, that's it. Label 11. Protect your skin from sunlight, even on a bright and cloudy day. Do not use sunbeds. All right. So quick recap. We said amiodarone capped dose 20 milligram with statin. What other medications have 20 milligram capped dose with statins aside amiodarone? Okay. Ali said ranolazine. IA said amlodipine. Okay. Is it just amlodipine or is it calcium channel blockers? Other calcium channel blockers as well. Diltiazem and verapamil as well. Amlodipine, ranolazine, amiodarone. Okay, they all have capped doses of 20 milligram with statins. All right. So this is my screen. Pulmonary toxicity, phototoxicity, potassium level, peripheral neuropathy, corneal microdeposits, cardiac function, hepatotoxicity, and thyroid. Those are the key side effects of amiodarone. Simvastatin. All right, so next question. So a 52-year-old man requests a private consultation in the pharmacy. In the consultation room, he reports that over the past week he has noticed frequent urges to urinate, but is only passing small volumes of urine. He also has lower abdominal discomfort. What is the most appropriate option to take? A, B, C, D, or E? So I've got a couple of E's. Well done to everyone who has attempted this question. Refer him to his GP. Why do you think we need to refer him to his GP? So GMAT said it may be BPH. Theophilus said it may be prostate cancer. Bless said it's complicated. I said possible UTI or BPH. Okay, well done, everyone. You guys are correct. Okay, generally, if a male patient is presenting with symptoms of UTI or urinary symptoms, you actually need to refer the patient. Okay. This patient has lower abdominal discomfort, which is not common in BPH. Okay, which is not common in BPH. But then it's always best to refer the patient to his or her GP. So if this is a confirmed UTI, what will be the treatment strategy? What will be the treatment strategy? So I've got nitrofurantoin. Is it for 3 days or for 7 days? It's for 7 days, yes. Remember, treatment of UTI in male patients, 7 days. Female patients, 3 days. What about pregnant women? Pregnant women is 7 days as well. Okay. And the first line is usually nitrofurantoin. Nitrofurantoin is the first line. Is that what's the what's the dosage regimen for nitrofurantoin? Yeah, so it's 100 milligram twice daily. What if we've not got the 100 milligram in stock? 50 milligram QDS. Yes, so it's either 100 milligram modified release twice daily or 50 milligram QDS of nitrofurantoin. First line, okay. Patients, what if the patient has got kidney impairment, renal impairments, EGFR of say 40? Can nitrofurantoin still be used? No. So what will be our alternative? Trimethoprim. What's the dose of trimethoprim in pregnancy? Or what's the dose of trimethoprim regularly? What's the dose of trimethoprim for UTI? 200 milligram twice daily. Yes, 200 milligram twice daily. That's the dose of trimethoprim. Okay, so remember for male patients, 7 days duration of treatment. For female patients, 3 days duration of treatment. For pregnant women, 7 days duration. Trimethoprim cannot be used in pregnancy. Okay, so if the patient is pregnant, then what are the other options? Let's say nitrofurantoin is also not. Okay, I've got amoxicillin. Yes. Can nitrofurantoin be used in pregnancy? Yeah. So nitrofurantoin can be used in pregnancy, but it should be avoided at 10. So S, it's not 25, it's 45. Okay, 45. That's the EGFR value that requires avoiding nitrofurantoin 45. All right. So that's it for nitrofurantoin and trimethoprim. In terms of, let me just have a look one sec. So what if this was a female patient experiencing back pain as well? lower back pain, would that be treat or refer? Why do we need to refer patients with lower back pain and symptoms of UTI? It could be pyelonephritis, that's correct. And what is the antibiotic of choice for pyelonephritis? Yes, cephalexin is first line for so always look at the question properly. Is the patient presenting with lower back pain as well? If the patient is presenting with lower back pain, then it could be a sign of pyelonephritis, which is a kidney infection. So in that case, we are going to have to give cephalexin. All right. So if this was BPH, can BPH be treated over the counter? What's the medication? So tamsulosin, yes, tamsulosin can be given over the counter. Okay, obviously there are some guidelines that the patient needs to meet for you to give tamsulosin over the counter, but yes, it can be given over the counter for benign prostatic hyperplasia. Canesten 150 milligram capsule. What's that? What's what's that used for? What over the counter condition is that used for? Thrush, yes. Can thrush be treated in men? Can thrush be treated in men? In what conditions can you treat thrush in men over the counter? So if the partner has thrush as well, if the partner has, yes, if it's contacted by the partner, then you can treat thrush in men over the counter. Okay? But if not, then you would have to refer the patient. And finally, what's the licensing, OTC licensing for treating thrush in women over the counter? What's the OTC licensing? What's the age? 16 to 60, yeah. So if the patient is between 16 to 60, then you can treat thrush over the counter. Okay, remember to also revise other criteria as well for treatment and for referral. For example, if the patient is diabetic, you need to refer, right? If the patient is having recurrent thrush more than twice in 6 months, you need to refer. 2 episodes in 6 months, you need to refer. Okay, so that will bring us to the end of today's session. I hope everyone found this session useful. Just let me know if you found the session useful. Okay, well done everyone. Well done everyone. I'll communicate the day of the next session on the group. Okay. And I will also try to upload these as well to the YouTube and I'll send the link. But please try and subscribe to the page on YouTube as well, the channel, so that you can be notified when I drop more videos. On that note, have a good day everyone. Thank you for joining today's session.